other section of the results, in terms of baseline characteristic, the median age was 34 to 48, predominantly consisting of females, 65 to 85. One study comprised of male, and two studies from Sub-Saharan Africa. Females were majority at 67.2, which is also expected. In terms of prevalence of diabetes, there was great variation, with one study reporting a high prevalence of both impaired fasting glucose of diabetes of 39.7%. Of note is that this study was done in Asia, one of the ethnic community that is associated, that is known as high risk for diabetes. And then we had a prevalence of 2% by the study of Glass et al. In terms of incidence rate, it also varied considerably from 0.2 to about 4.8%. And of note is that in all the studies that reported prevalence and incidence, there were no comparison groups. So we could tell whether the prevalence of diabetes was higher among the HIV infected compared to the non-HIV infected. The risk factors that were documented included the highlighted traditional risk factors, and the HIV-related risk factors that were cited were protease inhibitor exposure and persistent systemic inflammation. And of note is that it was cited that exposure to integrase strand transfer inhibitor was associated with a lower risk of incident diabetes. In terms of clinical characteristics, and that's to answer the objective 2, there are only 3 studies out of 21 that reported on chronic organ complications. One of them looked at the prevalence of diabetes-related complications from the time of follow-up, and it reported a high incidence of 16.6% from time of diagnosis, of which 11.5% were microvascular and 6.9% were macrovascular. Of the microvascular complication, the highest cases were of nephropathy, accounting for 7.8%. One of the other studies reported on the progression of chronic kidney disease among patients with HIV-developed diabetes, and it was found that progression rate was high at 18%. And the other one just looked at the risk of a subsequent acute coronary event, and it was also high among patients with diabetes in HIV and diabetes. There were those limitations with these studies. Number one, the narrative review was not as comprehensive as initially envisioned because there was paucity of data and also heterogeneity in terms of the available literature. And there was also great variation in terms of reporting morbidity statistics, particularly the incidence rate. In conclusion, the prevalence of comorbid diabetes among HIV persons ranges between 0.28 per 100 person years to 4.7 per 100 person years. The risk and the incidence of chronic organ complication in HIV-infected person is also high. It is not yet clear whether the incidence of diabetes mellitus among HIV-infected patients on heart is higher than that of the HIV-negative population. And also it's not yet clear what is the role of comorbid diabetes on the rate and incidence of chronic organ complications. My recommendation after this review is that more robust prospective observational studies are needed to clarify the various uncertainties in these study areas. Those are my references. Thank you very much.
I'm happy to see we are all hanging on for the last presentation of the day before we go for tea. I would like to invite Dr. Rilwan Mohammed. I call her 0.5 and she knows why. She's the head of Lance Diabetes Care Center and Chief Medical Officer at the Baobab Circle, which is a health tech startup in the UK. She's a member of steering committee of the WHO GCM NCD on women and girls. You're welcome, Dr. Rilwan.
Thank you, Jerry. First of all, Matiko and I think Mithi, I have good news for you. We're having, this data I'm about to present is local data from our patients here in Kenya. So if you are sad that you are having data not from Africa and Kenya, I have good news for you. So I'm going to present on the AROUSE study. So basically, the AROUSE study is a study done by a group of us from the Kenya Diabetes Study Group. It's a study that was funded by the Kenya Diabetes Study Group. And we have a group of us who are part of it. Okay, sorry. Okay, so, Okay. So basically, so the AROUSE study was done by a couple of us who are the co-authors who are mentioned there, Dr. Florence Kelly, Ann Wairagu, Saira Sokala, Nicola Okech, and Dr. Boni Ale, who are all members of KDSG. And we collected various clinical data, behavioral data, and there are multiple papers which are going to come out, so stay tuned. I'm just going to present one aspect of the paper, which is prevalence and associated factors of sexual dysfunction among female living with diabetes mellitus in Kenya. So this was a multi-center cross-sectional study. So why did we do this study, first of all? Because female sexual dysfunction is quite prevalent, and it's often underappreciated as a complication among people living with diabetes, especially women. So when we talk about sexual dysfunction, we always talk about erectile dysfunction, and this does not really attribute to the female patients, and so female sexual dysfunction is prevalent, and we really rarely talk about it. It's underappreciated. It's influenced by both physiological and psychological factors, and hence it impacts the quality of life of our patients quite significantly. And as I said, it's under-researched in Africa, and obviously in Kenya as well. So what was the aim of our study? We were out to highlight the prevalence of sexual dysfunction and its related factors among women living with diabetes. And this is majorly to enhance awareness and promote interventions aimed at improving their quality of life. So the method, the design was a multi-center. It was a prospective cross-sectional study. We collected data between April 2024 and August 2024. The study sites were the Lions Site First Eye Hospital at our Lions Diabetes Center, Gatundo Level 5 Hospital, and Aga Khan University Hospital, Nairobi. The sample size was 421 women who were recruited, and the data tool we used was the Female Sexual Function Index, which is the FSFI, which is a validated tool. Though it's self-reported, it's a questionnaire covering various domains of the sexual aspects in terms of female sexual function. And so it covered the desire, arousal, lubrication, orgasm, satisfaction, and pain. There was some retrospective aspect to this study in the sense that we had some data we collected from these patients previously collected in terms of their metabolic effect, their clinical data in terms of related to their diabetes mainly. So the study variables, the dependent variable obviously was the FSFI, which is a validated tool, and the score essentially is supposed to be less than 26.55 as a normal. The independent variables were what we collected from the retrospective data that we had, the socio-demographic, age, education, reproductive age at marriage, lifestyle, physical health, and the aim of us collecting all this data was to have various aspects of what can affect sexual dysfunction in females living with diabetes, and then duration of diabetes and the types of treatment and the types of diabetes as well. So it was descriptive statistics, chi-square, that was done by the statistician and not me. And the results basically were, the study, as I said, involved 421 women with diabetes, whose mean age was at 51 years. 94% of them had type 2 diabetes, 95% were employed, 92% were married, 50% were postmenopausal, and the mean BMI was at 30.8. We had a high prevalence of sexual dysfunction. 76% of women had female sexual dysfunction in our study, with especially low scores in desire and orgasm domains. Remember, the FSFI index was giving us these various domains which we were calculating for each and every patient. And so orgasm and desire seem to have scored the most there. So this is actually incongruent with most of the studies that we looked at. One study done in 2019, it was actually a review, and it put the estimate of female sexual dysfunction prevalence at 70%, so we're not so far off from the rest of the world. So the key associated factors when the data was unadjusted for any confounders was significantly associated. The factors that were significantly associated with female sexual dysfunction were higher education. So for those female who are higher educated tend to have more female sexual dysfunction, urban residents, longer marriage of duration, type 2 diabetes, use of oral anti-diabetes drugs, and higher diastolic blood pressure. Remember, this was unadjusted though, so there were other biases and confounders. So when we adjusted the data, we only found that older age and urban residents remained significantly associated with female sexual dysfunction when we adjusted for all the other variables and confounders. So there was no significant link between diabetes duration, the BMI, the menopausal status, and all that. So this is just so this is just the FSFI index, which we did, and you can see desire there was the lowest at 3, and orgasm followed there at 3.2. That was followed by 3.3 with arousal. So we really didn't have issues, a lot of issues with pain, dyspareunia, when it comes to female sexual dysfunction in the cohort of patients that we had. So the prevalence there is at 76%. These are the factors associated with the female sexual dysfunction. So like I said, we had the adjusted, this was the unadjusted. Remember, look at the p-value we had for age, and we had their higher education, those at university, but when we adjusted for the other variables and the confounders, we only found that the age and urban residents were significant risk factors associated with female sexual dysfunction in the cohort of patients that we had. So this is still the same. So in conclusion, this study highlights high prevalence of female sexual dysfunction among women living with diabetes in Kenya. And there were multiple contributing risk factors, however, predominantly age and urban residents. And so our recommendations are to enhance awareness of female sexual dysfunction, implement regular screening, use integrated management strategies in diabetes treatment to improve the overall quality of our patients. So all I'm standing here to say is that most of the female patients you're seeing in your clinics have female sexual dysfunction. They're not going to talk about it. One of the limitations we had for this study is that the FSFI index is self-reported. So there is that reporting bias that was there, but still we need to have a mechanism of bringing out female sexual dysfunction in our patients. The strength we had for this study was that it was multi-center in different socio-demographic status between the village doctor, Dr. Anu Eragu, and also Aga Khan University Hospital. But what we want to emphasize is that the prevalence that we think that our patients with female sexual dysfunction don't have sexual dysfunction, I wanted to dispute that using our own data. So please make sure that you have a screening tool for your patients. The FSFI index is a good one. You could just use it in your waiting room as you wait to see the patients. Thank you very much.
Rilwan, that was very interesting. Most of the times when the patients come to the clinic, we focus on the Omu husband, and the wife is there having sexual dysfunction. So I think that is very, very interesting to know that such a good study is coming out of KDSG. I would like to invite the other three who presented to come here to the stage. Dorcas, Matiko, and Caroline Mithi. We have their posters next to the KDSG KAP booth. I hope you have all visited the booth, so you can go look at the conference posters. And also I'll urge you to visit all the other booths for the pharmaceutical companies, because without them we'll not even be sitting here. So I don't know whether anyone has a burning, and it's one question per panelist. We need to go for tea. One burning question to each Okay. Okay. As we wait for the questions,
Excellent.
just give me a moment. I would like to invite Prof to just give her comments.
So thank you very much for your studies, and I think they were very interesting and across a broad spectrum of topics. I think what is interesting about this research is just the translation to clinical care also, and the practicalities of them. So especially for the lipid, when we think about the use of statins, which is in guideline, but we are not actually practicing that. It makes us, jogs our minds as to, just guideline use. And I think there are studies on guideline use even in different populations as we go along. So maybe that's something you could also look at. So thank you for all the studies. Rilwan, I did wonder about 51-year-olds. That's estrogen is going down as the base age for these women. So that will influence, I think, yes, a lot of your findings. So thank you. Thank you for this. I think I'm more keen to hear the comments from the audience.
Thank you.
People.
Thank you.
Irene,
Sorry.
can I just...
Okay.
Prof, thank you for your comment. So actually, the age factor which contributed to the female sexual dysfunction, it could be obviously the decline in the estrogen, because as you age, it showed that you have that. But actually also the duration of the diabetes could be a contributing factor because of the vasculopathy and the neuropathy. So that's what we were thinking along those lines in terms of the age. And the other factor, which was the urban residents, was there were studies which showed that the female sexual dysfunction in urban residents was contributed mainly to the social stressors, the sedentary lifestyle in the urban areas and all that, obviously contributing to metabolic risk factors which lead to that.
Thank you. Thank you. Those are very, Dr. Miodi from Mombasa, very interesting presentations. My question is to Dr. Matiko.
Sorry, please speak up, whoever is
There
talking.
was clinical inertia in the use of statins. And this is not just in Kenya or in Africa. It seemed to be everywhere. And as you know, there's been a lot of controversy about statins with regard to cognitive function. So could this be one of the reasons that there's a lot of inertia? And now that you are very aggressive with regard to prescriptions in Kisi, are you worried?
Matiko?
To start with the last, I'm not worried.
He's sad.
All right. For me, this narrative review has really made me interrogate what I do. You are seated there with the guidelines. We are the ones who do CMEs and preach about statins and other, interventions. But translating that to practice then becomes a problem. Clinical inertia, as you've mentioned, is one of those factors that we saw here. So there were patient factors, systemic factors, and clinician factors. So for me, as a call, post this review, we need to come up with models that would then enhance our clinical decision. So around clinical decision support systems. So you can't move from stage A until you've done, or you've checked whether your patient is on statins or not. Then if you decide to give them statins, then you need to know what their risk scope looks like. So then the dosing is equally appropriate. So beyond the prescription, the other part is just ensuring that we stick to the right dosage for that particular patient. And of course then, each patient would have their own risk profiles, hypersensitivities and the rest. So it's not about looking at the adherence without necessarily looking at the other profile that then would put a patient into detriment. And the other aspect that I hope we can develop is just models, patients before they see doctors and, pharmacy based interventions like reviewing those prescriptions after they have been adequately educated that they need to to have these patients on statin based on their risk profiles. Thank you.
Thank you for that. Musheru,
Okay.
ask your question, and I hope it's to a different panelist.
No, it's to Rilwan.
Okay.
Okay. How did your study factor in factors such as partner relationship quality, mental health, or even cultural attitudes towards sexuality, given that this is a very taboo topic in this area, and especially in Wairagu's center, Gatundu, where that is a rural area, given that 2 of your centers were urban and 1 was rural. So was that a consideration that you made, and how did you factor in those confounders? Thank you.
So I think it's not only Gatundu which was rural, even mine is partially rural, but like I said, one of the limitations was the fact that this is a taboo topic, and the tool that we use, although it's validated, it's self-reporting, so there is obviously some bias there, which I reported as a weakness for our study. However, it helped that the consultants in the clinic actually are very familiar with their patients. So most of us talk to our patients, and we made them understand that. Coming to the mental health aspect of it, we didn't pick that data as such because it would have really compounded that. But like I told you, statistically we adjusted for biases which were there so that we can, so that we don't pick all the risk factors that were there. As you saw, when we did not adjust, the risks were quite too many. After adjusting, the risk actually quite reduced. So that adjustment in our data is what we looked at to reduce the other confounders and the variables.
Okay, thank you very much.
Hello.
Any other question to a different speaker?
A question to Dr. Mithi. Thank you
There's
for the
someone in the audience?
presentations. Thank you for the presentations. My name is Dr. Farida, work as a physician in Nairobi County. So my question in the use of GLP-1 agonist. So recently we had a patient in clinic has been on 1 mg of Semaglutide. So we were planning to transition to 2 mg as a step-up treatment. Then she develops a rash on the left forearm, which she says worsens upon the injection. So we had to go back to our initial 0.5, which is she tolerated well. So my question is, what are the side effects associated with semaglutide that you have come across in your practice, and how have you gone about it? Then the other question is, patients who have been on other GLP analogs, say Victoza, liraglutide, you want to shift to semaglutide because of availability and cost. How do you transition that dosage? And then the other one is patients with pre-existing eye problems. There are patients in clinic who are obese. They've even had cataract surgeries. Would you recommend a GLP, say semaglutide, as part of their treatment for weight loss? How would you know a side effect as an eye side effect from a GLP? What is your expert recommendation on this? Thank you.
Thanks, Doc. So side effect profile, I'll combine the first and the third question. So the common side effects that we experience, so the common nausea, constipation, bloating, you can have hypersensitivity reactions to higher doses of GLP-1, semaglutide, especially at the site of injection. Ideally, what has been recommended for glycemic control is the 0.5 and the 1 milligram. If purely for glycemic control, that's the dose. If it's for weight loss, we have 2.4 milligram, what has been approved by the FDA, and that will warrant then the increase in the doses. So that may explain one of the side effects, hypersensitivity reaction, especially if the forearm site was the site of the injection. The other question was diabetic retinopathy. So there have been cases of worsening diabetic retinopathy in patients who already have diabetic retinopathy. And so for all patients with diabetes, they require an annual eye exam by the ophthalmologist to evaluate for retinopathy, but especially if you're putting them or you're going to put them on a GLP-1 analog for that. So that will be the transition. If they already have proven eye disease in terms of the worsened diabetic retinopathy from grade 2 onwards, you'd probably want to give them an alternative as opposed to semaglutide. The other question, how you'd be able to shift from one GLP-1 to the other, liraglutide to semaglutide, say for example, you'd basically, you'd just switch. So depending on your parameters, add thing, isn't it? But definitely semaglutide, you'd start with the lower dose at 0.5 for 4 weeks, 0.25 for 4 weeks, and then 0.5 for 4 weeks. And then now, if they tolerate, then you can go higher to 1 milligram. Yeah.
Thank you, thank you, thank you. One last question to, no, Dorcas. Anyone who has a question to Dorcas? Okay, no one?
The practical point is the screening for anyone taking care of HIV patients, screening for dysglycemia. Because now we are seeing more metabolic syndrome, yeah? So I think because we've used PIs quite a bit, those numbers might be a little higher because we see them in clinic as people live longer. So that was a good study. And I don't think, Dr. Muyode, I'm not sure there's hard, fast evidence for statins causing cognitive decline. And especially when we think about diabetes and it's vascular and the underlying mechanism is inflammation, then statins would actually be protective. So I think maybe you could talk about it with different types of dementia, but definitely diabetes related, I don't think there's any evidence for worsening cognitive decline.
Thank you very much. I would like to thank our presenters today. As I invite Dr. Wairagu to give the announcement, she says she's a village doctor, but if you check Gatundu level 5, if you Google, that hospital does not look like it's in the village. If anything, Kiambu is the one that should be in Gatundu. Karibu.
Thank you, Irene. We come from the same county, county number 22. If you look at the program, it shows that we finished the Q&A. There's a tea break. After the tea break, there was a gap that you're supposed to go, then you come back. But we want to also give the last talk just after the tea break. This is a dinner which is sponsored by Q Pharma. And even if you're not staying in this hotel, the dinner is for everyone. Even the talk is for everyone. So you go have your tea as you visit the booth.
Narrative review. So someone probably need to move my... Is it this one? Okay, so as usual, people from the peripheries never have any interest or conflict of interest, to be clear. So I have none. All right. So it's in the backdrop of an increasing burden of diabetes. 50% of the patients that we see will end up having cardiovascular events and mortality amongst diabetes. Africa as a region, we tend to oscillate at around 4% in as far as prevalence is concerned, compared to the global estimates of around 10% given by the IDF Atlas 2021. But what is really keeping us awake, or should keep us awake, is the fact that by 2045, it's expected that we'll have seen an increase of around 150% in the Africa IDF region. And indeed, some regions like the northern part of Africa are already at around 10%. So, in the morning we heard about SGL2 inhibitors. We've been hearing about glycemic control. But there are other modalities through which these cardiovascular events need to be reduced. And statins has been one of them, with a recommendation from major guidelines that anyone with diabetes between the age of 40 to 75 years should be on primary, statins for primary prevention. And importantly, they should be on at least moderate intensity statin dosing. And to think that dyslipidemia is not a problem, probably will be burying our heads in the sand. A study done in Malawi showed that 71% of diabetic patients had dyslipidemia. So it's not really a small problem that we have. Some of us, most of you, probably have put their patients on statins, so they realize this benefit. But there's a huge gap. Even on a cursory look, you'll still find that in our centers, probably some of us are guilty, we've not optimized the dosing intensity, leave alone initiating these patients on statins. So statins offer some benefits directly through the reduction of LDL cholesterol, triglycerides, and a slight increase probably in HDL, but there are those that we call pleiotropic effects that then act on the vascular bed to bring about vascular benefits. And that diagram there depicts exactly that. So in this narrative review, the main objective was to assess the prevalence of statins for primary cardiovascular event prevention among diabetes patients in the region of Africa, with the secondary objectives as highlighted there, but mainly to look at gaps, then facilitators and barriers to access and implementation of statins for cardiovascular event prevention. So this was a narrative review. We looked at, we started off with 159 studies, but through exclusion criteria, we ended up with 10 studies in Africa that then met what we required under the CASP analysis to look at the quality of these studies. So these are the results. Only 10 studies met that criteria. 6 out of 10, shockingly, were from Ethiopia, 2 from Ghana, 1 from Tanzania, and 1 from Botswana. All studies were cross-sectional studies with a cumulative population of 3,999. To our first objective, as you may see on the graph there, but I've highlighted, statin utilization ranged from 16.8% to around 17.28%. 6 out of the 10 studies actually had that statin utilization at less than 50%, a significant discrepancy as compared to what various guidelines recommend. So the predominant statin that was in use was atorvastatin, and while we were looking at lipid management, we also were looking at what other statins, lipid-lowering agents are in use. Because however much you want to optimize statin use, a good number, around 40% of those patients will still not be optimized. So one has to think about alternative or add-on treatment, and that includes populations that have hypersensitivity to statins. So, to my shock, during this review, only 1.5% of the patients were on ezetimibe. There were no any other agents that were used for lipid management in this population. So compared to what guidelines say, and most of these studies were using the ADA and the ACC guidelines, in nearly all the studies, as you may have seen, none go to 100% use of statins or lipid management, something that is really, really glaring and should leave us asking ourselves questions whether we are doing the right thing while seated in this room, in our clinics or various practices. The other thing, there was dosing intensity cardiovascular risk mismatch in the upward of 90% in the 10 studies. And this means, even with the lower numbers that were on statins, most of them would be on a low dose intensity as opposed to moderate or even higher depending on the cardiovascular risks. So there are some factors that were associated with an improved statin use, one of them being hypertension, comorbidity, advanced age beyond the age of 60, a longer duration of diabetes, among others. But for the barriers, one of them is, even if guidelines were present within your clinics or within the study areas where these studies were done, they were not being referred to or simply were not being adhered to. Another thing that came out was there were no baseline lipograms. Okay? Comorbidity and availability was another issue. Even if clinicians prescribed, then there was a problem in as far as patients getting those commodities. Then clinical inertia and follow-up irregularity were the other barriers and gaps. So compared to the major guidelines, which I've stated there, statin utilization still remains suboptimal. that exposes a large cohort of type 2 diabetes patients to cardiovascular events as well as cardiovascular mortality. Then we need to have multi-pronged approaches, multidisciplinary teams to ensure that we face this problem because the longer we leave our patients without these statins for primary prevention or lipid management, the more we expose them to the risk of dying. All right, so then we need to develop a model for increased use of statins. I think that's a call that I'll be making to this congregation seated here today, and we need to do more research. Now, out of the 10 studies, 6 are from Ethiopia. Then the others were distributed to 3 other countries. In Kenya, there's no data completely. And because I still have time, our professors, these prevalence studies that we keep on saying, oh, these are too basic and all, we are lacking data there. All right, so encourage those who want to do these prevalence studies so then we can collect this data. So one of the weaknesses, of course, is the number of countries that has data on this. So then there's a question about generalizability. And the strength then, this was the first narrative review.
Of South Wales. So you're all products of University of South Wales. So you are seeing our society is growing courtesy of that. So our next presenter is Dr. Caroline Mithi. Dr. Caroline Mithi was my intern at Gatondo Level 5 Hospital. But she's done so well, she's already doing her 3rd master's degree. The first degree in master's, is it the 4th one? I think it should be the 4th. I think she could be the most educated person around now here. She's a fellow of the Royal College of Edinburgh. She has done MRCP of UK. She has done her MD in internal medicine at the Aga Khan University. She went ahead and did PG diploma in diabetes and endocrinology, where she was my classmate. So then we went ahead together and we did MSc in diabetes. Now she tells me currently she's pursuing another master's in the same university in obesity and weight management. Wow. She's the head of endocrinology at the KTRH, that is Kenyatta University Teaching and Referral Hospital, and also the program director of the EXACOP, that is East Central and South Africa College of Physicians. So she's the director at that site of KTRH. So her thesis, which is a narrative review, is efficacy of semaglutide on glycemic control, obesity, and cardiovascular outcomes in patients living with type 2 diabetes. So I take an honor to welcome you for your presentation. Thank you.
Thank you, Irago. There are people who shape your career trajectory. Irago was one of them. She was an excellent physician when I was doing my internship. I'm presenting a topic that is close to my heart, semaglutide. People know it as Ozempic. It is the new craze in Kenya now. But let's see in the background of diabetes, obesity, and cardiovascular disease. Well, Matiko was sad that there was no study in Kenya. It was hard to get a study in Africa for these. And so this data is Western data, but we collated a narrative review of all the studies, and in particular the sustained studies, and we'll mention a bit about STEP trials. Green. Oh, great. So basically semaglutide, or we'll talk about a brief introduction in 10 minutes. So it is a GLP-1 analog. It's an incretin hormone. It's released by the small intestines, L cells, but it also increases glucose dependent, and this is in the background of patients who have diabetes, secretion from beta pancreatic cells, but also decreases the glucagon production still in the alpha pancreatic cells. So we know that patients with type 2 diabetes have a decreased incretin effect. And so semaglutide, and here we'll focus on injectable, that's subcutaneous semaglutide, has a long half-life, hence allows it to be injected weekly. So we did a narrative review examining the efficacy of subcutaneous semaglutide in glycemic control, in obesity management, and in cardiovascular outcomes, specifically in patients with type 2 diabetes. So the justification, we know that type 2 diabetes, now the guidelines say that for any novel medication to be produced, they have to show cardiovascular benefits. And now we know that majority of our patients with type 2 diabetes are actually overweight or obese, up until 86%. And we know that a reduction of 5% or more of body weight improves glycemic control and reduces cardiovascular outcome. There is need for treatments in type 2 diabetes that give us the whole package. That's glycemic control, obesity, and obesity management and improved cardiovascular outcome. And so my aim was to assess the efficacy of subcutaneous semaglutide on these 3 major outcomes in patients with diabetes. So my 3 primary outcomes, and we'll go through them. 1 is efficacy on glycemic control, and we assessed these by a change in HbA1c from baseline. Efficacy on obesity and weight, and this was assessed by a change in weight in kgs. And cardiovascular outcomes was assessed as major advanced cardiovascular events, and defined as cardiovascular death, non-fatal MI, and stroke. So methodology, it was a narrative review. We collated a lot of papers, RCTs, meta-analysis, systematic reviews. However, in this particular talk, we'll focus on 8. But patients who met the inclusion criteria, that is the papers, and were on stable doses of background therapy, we randomly assigned them. So the eligibility criteria, so we took studies with patients with type 2 diabetes who are on semaglutide alone or with other medication. The intervention here was just semaglutide therapy, and the included studies are as shown. So we actually skimmed through almost 1,000 papers. You'd be surprised. So FDA approved semaglutide in 2017, but this work was there 20 years before. Someone had started working on that. So we really sifted through papers, and we ended up with 16 papers, but we'll talk about a few today. So we'll mainly focus on SUSTAIN trials. That's SUSTAIN 1 to 7. 1 to 5 plus 7 was mainly for patients with diabetes. And so we had a baseline characteristics, and this is just a summary of the studies that we looked at. So we had a baseline characteristic. Age was 53 years across the studies. 50% were men. Duration of diabetes ranged from 4 to 13 years. That was important. What is important to know, remember I said 86% of our patients are obese. And here, the average body weight in these trials were 91 kgs, 90 to 93 kgs, and the A1C was 8.1 to 8.3%. So, on the first outcome, that's the glycemic change. So this is interesting to see that in patients who had semaglutide, so we had SUSTAIN 1 to 7. So in SUSTAIN 1, we had semaglutide 0.51, and we'll just mention the ones in bold. So we had a baseline change of around negative 1.6% in 30 weeks, whereby we had at least 72% of patients achieving a HbA1c of less than 7. That is significant, and that is consistent in all the SUSTAIN trials or in all the semaglutide trials. So the average for SUSTAIN 2 was around negative 1.6 with a higher dose, and around 78% of patients achieved a HbA1c of less than 7%. Interesting, so exenatide is also a GLP-1 analog, and a study had been done before, and so they looked at exenatide, and we saw that there was benefit in semaglutide over exenatide. So that was significant through the SUSTAIN trials, and we were able to show that. But this is a borrowed slide just to be able to collect everything that we've said. So the average change of HbA1c in these patients were anywhere between negative 1.6 to 1.8 with higher doses of semaglutide, and 1.5 with 0.5 milligrams of semaglutide. So that showed that it was efficacious. Then the second outcome was baseline weight changes, still on the same, So we had at least negative 4.5, a change in body weight for these patients, up until 6.1, and the highest was in Sustain 5, where we had a change of 6.4 kgs in that duration. So it may seem that it's a very small percentage in weight. You know, you just lost 6 kgs. But in diabetes, this is significant. And we remember we said anyone with an average loss of weight above 5% is significant for diabetes. And so we found up until 66% of patients will actually have an increase, a reduction in body weight of at least 5%. So still a borrowed slide, but it was significant to see that semaglutide, that is the light blue, that's 0.5, we'd have an average loss of weight of around 3.7 to 4, and the dark blue will be around, that semaglutide 1 milligram, will be around 4 to 6. So significant for us, enough. Now the third outcome was the cardiovascular outcome, and this mainly focused on the Sustain 6 trial. So Sustain 6 was really an older population. They had more cardiovascular risks. At least 83% of these patients had cardiovascular disease and chronic kidney disease. And this set out to look at the major adverse cardiovascular outcome. And this was significant in the sense that, and I want you to just focus on the cardiovascular death. Yeah, so at least 2.7% vis-a-vis 2.8, you know, there was that benefit. However, for stroke, this actually showed significant with a hazard ratio of 0.6 non-fatal stroke. And so, in summary, what are we saying? So semaglutide consistently reduced HbA1c, at least in the range of 1.4 to 1.8%, and at least 50 to 70% with the higher doses of semaglutide, that is 1%, attained a HbA1c of less than 7%. The degree of weight loss achieved with semaglutide, that's both 0.5 and 1 milligram, was significant, anywhere ranging from negative 4.5 to 6.4, and at least 45 to 66 achieved a weight loss of above 55, you know, above 5%, and that was significant for us. So in Sustain 6, which is the cardiovascular outcome trial, patients had 26% lower risk of primary composite, that was cardiovascular causes, non-fatal MI, non-fatal stroke, but we know that this number was driven because there was at least a 39% decrease in rate of non-fatal stroke. Wasn't part to our study, but it also showed there was greater reduction in renal outcomes. So what are the guidelines recommendations in view of these? So out of all these trials, the Sustains and other trials, the ADA recommended the use of GLP-1s in patients with type 2 diabetes, cardiovascular disease, chronic disease, or overweight, and obesity. So in conclusion, the GLP-1s like semaglutide have demonstrated improved glycemic control, great weight benefit, and cardiovascular benefit in patients with diabetes, which was this study, but we've also seen in patients without diabetes. Thank you very much.
Thank you very much. Her talk is actually in line with our evening dinner talk today, which you're invited for. So the next person I'm going to introduce is Dr. Dorcas Obare. She's a physician with specialist training in diabetes from the University of South Wales, and she practices in Nairobi. She's keen on whole body wellness and thus strives to achieve, to address each individual's concerns, touching on all aspects of health according to the WHO definition of health. Apart from her passion from diabetes management, she strongly advocates for patient education, and she strives to ensure that patients assume active roles in their diabetes care. In addition, she hopes to reduce the prevalence of diabetes and its related complications by optimizing self-care among patients through patient education. You're welcome.
Thank you very much, Dr. Irene, for that kind introduction, and for my two colleagues who've gone before me. Excellent presentation and job well done in your presentations. Sorry. As rightfully introduced, my name is Dr. Dorcas Obare. I'm a physician and diabetologist, currently based at the Mama Margaret Hospital. I'm sure many of you are not familiar with that facility. For the purposes of this presentation, I have no interest of conflict to declare. So as a partial fulfillment for the award of MSc, Master of Science in Diabetes, I embarked on a narrative review to describe the epidemiological and clinical characteristics of patients with HIV infection who develop comorbid diabetes in the course of their disease. Sorry. Yeah? Okay. So as way of background, why did I decide to choose this study area? HIV infection is now considered a chronic manageable disease with good prognosis, with majority of people living with HIV having a lifespan that is similar to their HIV negative counterpart. However, this increase in lifespan is associated with increased risk of metabolic conditions, key among them being diabetes mellitus. Unfortunately, the frequency and also the clinical course of diabetes in this cohort of patients is not yet fully understood. So the purpose of this review was just to describe, to shine some light on the epidemiological and clinical characteristics of HIV-infected persons with comorbid diabetes. The objectives of my narrative review was, number one, to provide a comprehensive description of the epidemiology of patients with HIV infection who develop comorbid diabetes, and also to elucidate the clinical characteristics of patients with diabetes, HIV, focusing on the occurrence of chronic organ complications. So what does the literature tell us about this area? Now, thanks to the widespread availability of highly active antiretroviral therapy and also its enhanced efficacy, a new era among people living with HIV has been ushered. This era is characterized by reduced incidence, reduced mortality, and increased prevalence, and also enhanced life expectancy, and increased risk and incidence of metabolic disorders, key among them being diabetes mellitus. As of 2021, according to the UNAIDS report, the prevalence of HIV infection had gone up to 38.4 million from a previous report documented in the year 2019 of 36.8. And we all know that 70% of people living with HIV infection are found in sub-Saharan Africa. So this is a problem that majorly affects us in the sub-Saharan Africa. There are also reports that the prevalence of diabetes mellitus is 38% higher than that documented in people without the infection. And the incidence has been shown to be attributed to both the traditional risk factors for type 2 diabetes and HIV or HIV-related specific risk factors. The HIV-related specific risk factors that have been documented in literature include prolonged exposure to heart, thymidine analogs, dyslipidemia, and also lipodystrophy. Apart from the changes in morbidity and mortality indicators, there's also been change in demographics of this patient and also the cause of mortality. Cardiovascular disease is now emerging a significant cause of mortality in this cohort of patients, and it's estimated that it contributes to about 11% of total mortality in this cohort of patients. The picture shows a bar chart from the study by Smith et al. That basically shows the causes of mortality among HIV-infected patients from the year 1999 to 2001, and you can see cardiovascular disease, the area that is shaded, the area that is shaded light blue is it's contributing to about 11%. So where do these two morbidities meet? So studies have shown that both HIV infection and diabetes are associated with persistent background inflammation regardless of the level of control. Inflammation has been shown to play a role in the development and propagation of diabetes-related complications. It is unclear how the double burden of inflammation affects the occurrence and progression of chronic complications among these patients. Available guidelines with regards to management of diabetes recommend that people living with HIV infection with comorbid diabetes should be followed up and managed as using the guidelines available for the non-HIV infected people. And then also in addition, most of the risk engines for estimation of cardiovascular risk do not include HIV infection as one of the parameters for risk estimations. So in the research methodology, before embarking on this research review, the study protocol was reviewed and approved by the Ethics Committee of the University of South Wales. And following a very elaborate search strategy, a comprehensive search was conducted in 3 main databases, PubMed, Google Scholar, and